Good evening, everyone. Thank you for joining us this afternoon. Welcome to our town hall. My name is Dr. Veronica Womack, Executive Director of the Rural Studies Institute at Georgia College and State University. I am so honored to serve as your moderator for this program this evening. We're gathered this afternoon for a fantastic program sponsored by Georgia CEAL entitled The COVID Gap in Rural Communities Town Hall. The COVID gap in rural communities has been very, very impactful. So, as we know, town halls are to be engaging and interactive. And we hope that you will participate in today's discussion by asking questions and being active listeners. Just a few housekeeping rules. Please keep your device muted unless you're speaking. We also welcome questions. Please raise your hand or type your questions or comments in the comment section. Just a quick overview of how we will engage this afternoon. We will first hear from Dr. Akin, who will discuss how Georgia CEAL was formed. Next, we will talk briefly about our objectives this evening. We will have introductions from our panelists. I will give you some facts about COVID in rural communities, and then we will begin the presentations from our great panelists. Next, we'll have time for Q&A. We'll also hear about various resources provided by Georgia CEAL. And we will end our call tonight with a call to action by our panelists on how we can assist our communities to fight this virus. So let's first hear from Dr. Akin about Georgia CEAL.
Thank you so much. And thanks to everyone for making the time to listen, to prepare your questions and comments as we think about how we can work together to make Georgia healthier as we respond and rebound from the pandemic. So Georgia CEAL is the Community Engaged Alliance Against COVID Disparities, and it is one of 21 sites funded by the National Institutes of Health to bring together community leaders, clinicians, researchers, and basically anyone or organization that is dedicated to a healthier Georgia. And so our goal is to ensure community co-created, community translated, and community transformational work that increases health communication that is community responsive, that helps people to feel comfortable in the ways that they can mitigate and protect themselves from disproportionate hospitalization, illness, and death related to COVID. And also, we want to have transparent and safe dialogues for people who are considering getting the vaccine. And so at the end of the day, Georgia CEAL is designed to ensure that Georgia is healthier, both as we walk through this pandemic and beyond. And so you'll hear a little bit later about some of the resources that you can access through Georgia CEAL. But more importantly, through events like this evening, we want to create safe spaces to talk about where we are and really amplify the importance of engaging priority communities towards COVID response. So thanks for being here, and we look forward to your questions, comments, and a rich dialogue as we consider the path forward.
Thank you so much, Dr. Akin. Tonight, just to recap while we're here, we're going to discuss the urgency of COVID-19 in our rural communities, the benefits of vaccination, how the vaccination gap in rural communities is a barrier to stopping the spread of COVID. And finally, tonight, we will provide unique opportunities to understand and engage migrant and immigrant communities. So thank you again for being here. So now let's have introductions from our panelists. First, Dr. Akin, is there anything you would like to share with us in your introduction?
Well, thank you again. So, I'm a professor of community health and preventive medicine at Morehouse School of Medicine. And as that title suggests, it's more than a title. I really see myself as a bridge between communities and the academy in the pursuit of trustworthiness. We know it takes understanding and elevating community wisdom to ensure that we as researchers and clinicians can do our best to be responsive and develop programs and interventions that are sustained not just for, but by communities. So I'm also Associate Dean for Community Engagement, and that involves bringing together beautiful and important thought leaders like those who are here today. So again, glad to be here.
Thank you so much, Dr. Akintobi. Dr. Bastian, could you speak a little bit about your work, who you are and what you do?
Sure. Thank you for the invitation to be a part of such an important discussion. So my name is Gilbert, which is a mouthful. So most folks call me Gigi Bastian. That name is French, originally from Haiti. I am assistant professor at Morehouse in our Department of Psychiatry and Behavioral Sciences. I'm a clinical psychologist by training. And my work largely centers around the interface of mental health and culture, with a particular emphasis around trauma and natural disasters, but also with a lens to understanding the unique mental health needs and challenges of immigrant and refugee communities here in the States, which is the context from which I'll be speaking tonight about the unique COVID challenges for those groups. So it's a pleasure to be here and looking forward to a great discussion.
Thank you so much. Ms. Kavitan?
Good evening, all, and thank you for this opportunity. My name is Kavitan, and I'm here to represent Community Organized Relief Effort, CORE. I'm the South Central Georgia area manager for them, and we are working all across Georgia, especially in South and Central Georgia, with the rural health and priority populations. I have a specialty in public health, and I'm excited to be here with you all tonight. Thank you.
Thank you, and I apologize, Ms. Kavitan. Sorry about that. Next, we'll have Ms. Scaro.
Good evening, everyone. I'm so pleased to be here, and thank you for the invitation. I work with the University of Georgia, Cooperative Extension, and the College of Agricultural and Environmental Sciences. And we are so pleased to partner with many of you on vaccination education, vaccine education, and especially in rural Georgia. I am the administrator in 41 Southwest District counties, and I work with our faculty members out in the counties to learn more themselves about vaccine education and be able to translate that information to the clientele they work with at the grassroots. And of particular interest to us and the projects that we have now are communicating with our Hispanic audiences. As you know, we have many migrant farm workers in this area, and even Spanish-speaking farm workers who are not migrants, so to speak, but have put down roots here in South Georgia, and yet they can be sometimes isolated from the sort of information that they need. And so we are very excited about working with that population to provide education and help them overcome many of the barriers that they face when they are looking at vaccines, vaccinations, and what it all means, especially through COVID-19. So thank you for this opportunity. I look forward to talking with you all.
Thank you very much. Ms. Gruner?
Yes, I'm America Gruner. I'm the founder of the Coalition of Latino Leaders in Northwest Georgia. We are in Dalton and the areas around. And we have been working as a grassroots organization against COVID since 2020. And we have a lot to say about what we're going through and how we have worked in the community for the Latinos in the area to understand and to make the information their own, to do something about it. Thank you.
Thank you. Dr. Stafford?
Good afternoon or good evening, all, and to the audience. I'm Charles Stafford, retired physician after 35 years of primary care in Southwest Georgia. My specialty areas were obstetrics and gynecology and primary care for women.
Thank you so much. I'm sorry. I'm not sure if you.
That's enough there.
All right, Dr. Stafford, thank you. And Dr. Foz, welcome.
Well, thank you and good evening to everyone. I'm Dr. Norberto Faz, born and raised in Puerto Rico. I'm associate professor of medicine at Morehouse School of Medicine, also associate dean for clinical affairs at the VA for the great Morehouse School of Medicine. I'm the liaison between the affiliate VA Medical Center in Atlanta and Morehouse School of Medicine. I'm also a member of Georgia CEAL and very honored to work with Dr. Akin and be with this great group trying to share information and help our communities, specifically underserved communities, to fight against COVID-19. I'm also a co-investigator for the Novavax study, which is a vaccine, COVID-19 vaccine study that Morehouse School of Medicine.
Uh-oh. I don't know what happened to Dr. Foz. Well, hopefully he will rejoin us, and we are so excited to have such an esteemed group of people this afternoon to talk about rural communities. Okay, you're back, Dr.
Yeah,
Foz.
I don't.
To finish?
Yeah, it must have been my Wi-Fi, so I apologize. So I was saying that I'm a co-investigator for the COVID-19 vaccine trial, Novavax, at Morehouse School of Medicine. Morehouse is one of the about over 250 trials, site trials for the vaccine. And I'm also part of the COVID-19 prevention network in the United States and help with Morehouse in terms of education and also administration of vaccines to underserved populations. So again, sorry for the technical issue, but I'm just grateful to be here.
Oh, thank you. And we're so excited to have you and that you were able to come back so quickly. Now I'd like to share a little bit about some of the data that we'll be talking about this afternoon. And please bear with me. There's a lot of numbers here, but this is very important to provide some context. So as of November 30th, more than 48,581 people were hospitalized for COVID-19 in the United States. And that number was down from more than 100,000 at the end of August, according to the Center for Disease Control and Prevention, a level not seen since January amid the winter surge. From late August to late November, the 7-day moving average of cases declined from 160,000 to 90,000, and in the last week at 85,000 people. On November 13th, there were 6,392 new hospitalizations from COVID-19, the same average of hospitalizations from 2 months prior. Let's look at Georgia. The Delta variant represents 99.2% of cases. From just 2 weeks ago, 7,607 cases, so we're up 12% with cases in Georgia. Hospitalizations were down 3%. Deaths up 56%. We have a lot of work to do. The Delta variant is believed to be more than 50% more contagious than the original strain of COVID. A person infected with the Delta variant carries approximately 1,000 more copies of the virus in their respiratory tract than those infected with the original strain. Unvaccinated people can get infected with the Delta variant within seconds versus the approximate 15 minutes of exposure required for the original strain. This is very important. The ratio of unvaccinated individuals who are hospitalized for COVID versus vaccinated people is approximately 25-1. So the vaccine still works. Actually, out of over 5 million people who have been fully vaccinated in Georgia as of December 2nd, 76,950 had breakthrough cases, less than 1%, actually 0.014% breakthrough cases. 3,527 hospitalizations, and 1,341 deaths, 1.7%. So we see that the vaccinations do work, and they're very important to curbing the spread of the virus. So I'd like to now just remind people to please stay on mute unless you're speaking, and we are about to get into our presentations for tonight. I'd like to start with Dr. Akin. Okay. So could you please share the importance of eliminating the gap in education and the continuum of care in rural communities? Will you help us to understand more clearly what is happening? How did we actually get here? And how the Community Engaged Alliance Against COVID-19, or CEAL, is working to end both disparities and this pandemic. And finally, what opportunities exist for those who access this forum to participate and to contribute?
Thank you so much, Dr. Womack. Lots of questions, and I'll do my best to answer them as comprehensively as possible. So I'll start with the good news, and that is that many of you who are likely listening or tuning in this evening, and all of our panelists are standing in that gap through representing rural and immigrant communities, for serving them, understanding them, and then taking action. So there are many organizations and individuals, many of whom are represented on this panel, that represent the lived experience or the intent to establish trust and relationships so that we can not only understand, but then take action together. So how did we get here? And so, as COVID-19 continues to be a reality for us nationally, we know that 46 million Americans reside in rural communities, and they bear an increasing burden from the pandemic. And this burden quite often outpaces those of urban communities. And so, unless stakeholders act with extraordinary speed, which is what many folks on this panel have been doing since the beginning of the pandemic, the impact on lives and livelihoods in rural communities will continue to be worse. But we must remember that the issues and the important opportunities to address the health of rural communities did not begin with the pandemic. Oftentimes issues of access are discussed in terms of, in our state, the fact that many rural hospitals closed over the past 2 or 3 years. And so oftentimes those hospitals represented the primary point of care for many in rural communities. But when hospitals are the primary way that people were getting their preventive care, most of that care was sought when things were all the way to the right end of the spectrum. And I don't mean right in a good way, meaning when issues of cardiovascular health, diabetes were already so far down the track that there was more damage control than prevention. And so with those realities at play, it's no surprise that COVID came and created more important issues and opportunities to do things better. And so there are intricacies related to poverty, limited access to health care, and particularly for immigrant communities that are also rural, the issue related to fear of legal repercussions, even in considering going to get a vaccine. The fact that there is such a need for education to tell people what is needed when they're considering getting a vaccine or getting health care for that matter, really place vulnerable immigrant rural communities within the U.S. at a higher risk for acquiring COVID-19 and then developing severe COVID. So I want to just introduce a term that most of us may be familiar with, but even if you're not familiar with this term, it represents the opportunity for us to understand, and that is the term intersectionality. None of us are defined just by what we look like. There is what we do, there is where we live, and the access to education and care, all of those things create layers of identity that can serve as barriers or facilitators to us doing better in times of public health crisis. So what we want to do today is really talk about those multi-layered realities of who all of us are, but particularly for rural and immigrant communities as a unique opportunity to take action. And I think the panelists today will share great perspectives on what they are learning and seeing. But that's what we know right now, and I look forward to hearing from others with insights that I've not shared. So hopefully that sets the stage, Dr. Womack.
Thank you so much. It does. You provided us with some very important information. Now we'll move to Ms. Kavitan. Uh, could you tell us a little bit about the core response organization? I've been hearing a lot about that. How is it addressing the COVID-19 epidemic? And who are you collaborating with to promote vaccine education and uptake? And finally, would you like to share any insights on COVID-19 advocacy and community organizing? Anything that you'd like to share with us?
Yes, thank you so much, Dr. Womack. I'll do my best to answer the questions. I will share a few slides with you all to give some images.
Okay.
Tried it earlier. Talked about this earlier. Hopefully this will work.
Okay.
In the meantime, I can go ahead and give an overview about CORE. So CORE is Community Organized Relief Effort. We are working around the U.S. and different countries as a disaster response organization. I think I got this now. While it's uploading. So we are currently operating in 6 states and 3 different countries, working on various projects, including COVID testing, vaccination, and community outreach. We are a crisis response organization serving emergency relief, disaster preparedness, environmental resilience, and community building. So CORE began operations in Georgia in March 2020. We began in Metro Atlanta and the surrounding areas with COVID testing at the time. We initially began partnering with local boards of health, including Georgia Department of Public Health, to host mobile testing and vaccination units across Metro Atlanta. We expanded to South Central Georgia. Here we go. We expanded to South Central Georgia in April 2021. And here's a map of our operations in all of Georgia. The yellow dots are where we have held different unique sites so far. The gray area is our operations in North and Metro Atlanta, and the green is where our South and Central operations are. So in South Central Georgia, currently we do have 7 mobile units that are serving 9 different health districts, including the areas based out of Clayton, LaGrange, Columbus, Albany, Macon, Dublin, Savannah, Waycross, and Valdosta. So in South Central Georgia thus far, we have hosted over 940 vaccination events, vaccinating over 13,000 individuals. And here are some of our data from our vaccination events so far. Our gender has been about 58% male and 42% female. And there's information here also about our race and ethnicity demographics. Our ages have mostly been from 16 to 64. But as we are starting with pediatrics, that could expand our ages as well. For race demographics, it's been about 33% African American, 32% Caucasian, other about 25%. So this was just a little of the demographic information we wanted to share about are populations that we have been targeting in the South. We do choose most of our sites based on social vulnerability index. So we use a combination of community-based organizations, community partners, SVI data to choose where we should go have sites. We try to target areas where there isn't access to vaccination, where the closest vaccination site is over 15 minutes away. And so our goal really is to bring the vaccinations to these areas, to the populations that don't have easy access, and to the areas that would like more education, more outreach in the area. So as I mentioned before, the yellow dots are where we've hosted sites. And as you can see in South Central Georgia, the darker area is a more vulnerable area. And those are the areas in which we have had vaccinations or in continuing to find partners in these areas to serve the community. We accomplish this with our site development and community outreach team. We partner with all kinds of organizations. We've partnered with the Port Authority at Savannah to go on board ships and vaccinate crewmen who have come from Philippines or India, and they haven't seen their family in a year because they've had to quarantine. And with this vaccination, they finally got to visit their family. We've partnered with chicken factories at 5 in the morning doing vaccinations for third shift and first shift. So we're really about flexibility, meeting the needs of the community where they are, whether it's early morning site, late sites, long days, short days. We've been at any kind of event that you can imagine.
Okay, just to remind everyone to please be on mute while we.
Okay. Along with our site development team, we have an extensive community outreach plan where we use the SVI data and research the community profile to find target communities that are vulnerable and underserved and do not have access to vaccines. Within those communities, we work to find trusted community partners. Really, the key to the community members that we have found is finding trusted organizations that have already built connections with community members. As we're coming in as an organization, but they live and work in the community and have these partnerships that community members do trust. So once we have these partners, we work with them however they need, whether it's to host a vaccination event, to speak at community events, provide education at any tabling or community events, really in any way that the partners know in the area to bring education or access to vaccinations. So between our site development team and community outreach team, we work closely with community partners to reach community members in rural and high priority populations to bring the access to them and the education to them so they feel comfortable getting vaccinations. So thank you very much. We look forward to hearing the rest of the presenters as well.
Thank you so much. Dr. Bastian, mental health and behavioral health are emerging as a sub-epidemic. Can you shed some light on what this means and how it's impacted immigrants and migrants in both rural and urban areas of Georgia? And finally, what opportunities exist for those who access this forum to collaborate with you or to use your services?
Absolutely. Happy to share more and to address those questions as best I can. Let me try to
Thank you.
pull up some slides if I can. Okay. Hopefully those are visible.
Yes.
You're on mute, Dr. Bastian.
Yeah, if you could unmute yourself, please, Dr. Bastian.
So
Yeah.
sorry about that. Everything was flowing till it was my time, and then the camera starts to do. Okay, here we go. You're still able to see slides.
Yes.
Okay. Yes, so I was saying that one of the things that I failed to mention at the top in my introduction is that one of the hats that I wear at Morehouse School of Medicine is leading our Office of Global Health Equity, which has, through a partnership with our National COVID Resiliency Network, been engaging our migrant populations towards addressing some of the very COVID challenges that myself and my co-panelists are addressing tonight. So I'll be speaking about those things, but wanted to come at it with some appreciation for some important context that can get lost in these conversations that we have a particular eye to at Morehouse School of Medicine. One has to do with appreciating the roots and the history of some of the inequities, some of the disparities, challenges facing our migrant populations, right? So that involves things like considering the circumstances that bring about migration and lead folks to our borders here in the U.S. and understanding the factors that drive those waves. We're also intentional about bringing a consideration of culture. We'll talk a bit about linguistic and cultural considerations and how we're engaging migrant populations, but also with an eye to thinking about issues of behavior and mental health. I'll speak to those and the societal context in which this pandemic is playing out and that we're having to attend to the needs of these communities. And finally, we acknowledge that the complexity of the challenges facing these populations are beyond what any single entity, any single institution, any single discipline can undertake. And so we strongly advocate working in collaboration and leveraging strong coalitions to more effectively address the needs of these communities. And so before I proceed, I thought it was important to establish some shared understanding of terminology that I'll be using throughout. And so when I intentionally in my title referred to this as migrant populations as opposed to merely immigrant or merely refugee, right? And so that encompasses a number of different groups that terminology of migrant populations that can involve folks like our migrant farm workers, which have been referenced earlier in our conversation, who may have different levels and different types of immigration status in the U.S. It also involves displaced populations, right? So these are often groups where there's less of an element of voluntary choice to leave their native countries as some of the other immigrant groups. So often those migration trends are catalyzed by natural disasters and things that are largely out of folks' control. Then we of course talk about immigrant communities where there's a bit more of a sort of decision, though we could have some discussions about that in terms of taking on migration to leave home and resettle in a new cultural environment. We also, some of our work also touches asylum seekers, those folks who make it to our borders with challenges that place their very lives in danger often, and are seeking that final sort of category of refugee, of having full legal status here in the U.S. So all of these and probably a number of other groups are encompassed under what we're talking about in the way of migrant populations, right? And so what we know is that there are a number of unique challenges facing these communities that are really coming to a head and at times been exacerbated by what the COVID pandemic has brought to our shores here in the States. We know that there's a disproportionate impact for these communities that are largely driven by pre-existing points of vulnerability, right? So we know, for example, cultural and linguistic issues limit access to resources, to needed supports. We know there are economic challenges, right? So poverty is a significant challenge facing these particular populations. There are issues of housing, overcrowded housing, where you have a number of folks living in the same space that obviously will create some risks in the way of the spread of the COVID virus. Employment places these folks in peril as well. We know that Throughout this pandemic, we've been hearing about essential workers, those folks who we rely on to keep this country moving, even through the challenging past couple of years that we've been through. Whether it's in the hospitality industry, whether it's in food and restaurants, we know that these populations are overrepresented in those spaces, and that instability of employment certainly creates hurdles and challenges in the way of health functioning that we're also seeing play out when it comes to COVID. Significant challenges around education, right? So if you think about all that perhaps you experienced personally or that you witnessed in your families and your communities around pivoting to a digital education space, can be a particular challenge for this community when you factor in access or lack of access to needed technology and supports, as well as the linguistic and cultural challenges I referenced earlier. And finally, what we know and have done significant work around at Morehouse School of Medicine is that issues of access to healthcare can obviously have significant implications for this group. And so compounding these challenges, you have additional challenges around mistrust of healthcare and other established systems here in the States, right? So folks are concerned about immigration status and how that will create issues as they attempt to access testing, vaccination, those kinds of things. So those become important hurdles to overcome as well. And we come at these challenges with, so my colleague, Dr. Akin, introduced some terminology. I'll add another term to the mix that we reference a lot in our global health office, which is bringing a global perspective to tackling these challenges. And so that gets at the notion of leveraging the work that Morehouse School of Medicine has done around tackling health disparities here in a local U.S. context, seeking to learn from our partners in our global community and looking to see how we might bridge those bases of knowledge to address the challenges impacting our migrant populations as it relates to COVID. And so I referenced that our Office of Global Health has been working closely with our National COVID Resiliency Network and starting to move towards solutions to addressing some of those challenges I've referenced. So some of that involves, you'll notice that I don't highlight a ton in the way of numbers and data relevant to this group, and it's because we know there's significant challenges to even adequately capturing what the trends are, what the needs are, often because of some of these issues of mistrust and access. And so that's an issue that we're tackling head on in terms of drawing from our network of partners who have established relationships and trust with these communities to gather more accurately the data that can inform our action. We've also been doing some important work around linking folks to care as it relates to COVID, whether that involves getting testing, accessing treatment where needed, and certainly vaccinations, and that's involved going on the circuit of our faith communities, faith sites to do some health and public health education and awareness raising. To really empower these communities to be able to advocate for their needs and to access the needed resources to overcome the COVID pandemic. And again, I referenced the importance of the partners that we're engaging, the coalitions of support that are critical to the work that we're doing. And one of the more interesting, I think, examples of this has been the work we've been doing in collaboration with our faith community in the Atlanta area. And in particular, some of that work has zeroed in on the mental health challenges that COVID has either exacerbated, that were pre-existing challenges, or new challenges that are being brought to light as folks have had to deal with a significant slowdown in their activities, less access to supports that they relied on. And so we found that while we may have the right message in the way of how folks can tend to their mental health challenges, often our faith leaders, our trusted community leaders are the right messenger to move those message points forward. And we come at that work with an intentional trauma-informed care lens, right? So that is informed by an understanding that there's significant trauma challenges and trauma exposure throughout the migration process, right? So there are often traumatic experiences back home that triggered migration for a lot of our folks in these populations. but also throughout the process of resettling here in the States, there can be additional stressors and adverse experiences that will have significant implications for health outcomes. So we come with an eye to attending to all those issues while also working to address capacity, right? Ensuring that we have the needed workforce to tackle the needs of these communities. So one initiative we're taking on currently is training a cohort of young folks, so from the ages of 18 to 24, and providing some training for those young folks to become certified community mental health workers who are equipped with the training, the tools, the messaging to go forth and address some of the unique challenges that are coming up. And we're doing that work in partnership with faith leaders in the local Haitian diaspora community here in Atlanta. So also wanted to reference a couple of resources that are relevant. Certainly the APA, both APAs, really both the American Psychological and Psychiatric Associations have been attending more to thinking about what some of the unique mental health challenges for migrant populations might be and how COVID has contributed to some of those challenges. NAMI has put out some resources as well with an eye to addressing some of the unique challenges of this community. And so those are some of the initial remarks that I wanted to share, and look forward to addressing additional questions from our attendees. So I'll stop there.
Thank you so much, Dr. Bastian. And wow, thank you, Dr. Akin and Ms. Kavitan and Dr. Bastian for all of this amazing work that you're doing and the information that you're sharing. The work of CEAL, the work of the Morehouse School of Medicine, the work of the core response team. This is just some really important information that you're sharing with us. I'd like to take this opportunity to ask folk to please put their questions in the comment section. We look forward to hearing from you. We'll move on and shift gears a little bit to talk about one of my favorite topics, and that's agriculture, of course. And I'd love to talk a little bit with Ms. Scarrow about the pandemic and how it is impacting rural communities and those working in the agricultural industry. So, Ms. Scarrow, if you could please just share with us what you're seeing and hearing from migrant workers and their communities, any challenges that they're facing, and how they are working to overcome them.
Thank you so much. I think I have loaded my screen to share.
Okay.
Does anyone set? There it is. Okay,
there
wonderful. Okay, thank you so much. It is wonderful to be with you. Like I said, and I so identify with the other panelists and what they've shared. It's wonderful to make these connections as well. At Cooperative Extension, we got into this space and this concern because we work so closely with our agricultural community and our producers and farmers. And we know that the safety of our food and that supply chain for food is so important to our whole state and beyond. And so we were actually contacted from some of those by some of those ag producers to help them with resources for the migrant workers, for the Hispanic farm workers. We've helped in the past on some of the issues that they've faced and trying to communicate the education in Spanish to this population. And so we responded to that, and Extension is well suited with an office in each county of Georgia and the ability to connect our faculty members in those counties straight to the clientele who needs the education and information. So just to share a little bit about what we've done, as you know, as already has been expressed, this data is from November 8th, so about a month ago. The Hispanic Latino community has been greatly affected by COVID-19, and if you compare the percent of population that identifies as Hispanic Latino with the percent of cases of COVID-19, confirmed cases when ethnicity is known, it's much higher, the percentage rate among this population. So 15% of cases have been among that Hispanic Latino audience. And so this is of great importance to us. They're not the only underserved, underreached group of or even migrant group, but they're definitely one of them. And we are very much in tune with that population here in Southwest District, where I'm located. But why the Hispanic farm worker population? Well, in 2020, over 700 outbreaks in meat packing and food processing facilities led to a 40% production decline. So again, that food chain that's so important to all of us is greatly affected when these processing plants are shut down. And then 75% of all positive COVID-19 cases in agricultural workers were in the Hispanic Latino population, and this in spite of them only representing 37% of all farm workers. So again, the high rate of cases that we were seeing. And we did a survey with the Georgia Fruit and Vegetable Association with 114 of the growers that we are in communication with and support. And it's estimated that Georgia has at least 10,600 seasonal, often Hispanic agricultural workers and 1,739 full-time workers. So we had a target population, and through our partnerships, we felt like we could help in this area specifically to get the education out. So the goals and objectives that we had were to create that research-based education around COVID-19 and its vaccines, and remove barriers to accessing not just the education, but also the vaccines. Increasing vaccination rates among Hispanic agricultural workers was also very important in our objectives. So the overall goal, again, was to protect the health and prosperity of Georgia's farming enterprises through vaccine education and outreach with Hispanic farm workers for this specific project. What we've done so far is I led 3 focus groups with Hispanic farm workers on farm sites, and it was so fascinating to be in conversation with them and to hear their feedback. They helped us identify barriers to receiving the vaccine. Of course, they expressed a lot of fears of side effects. They expressed fears of how the vaccine could potentially interact with prescription medicines that they were taking. They also expressed some cultural beliefs about vaccine, the intent of it, what was behind it all, were there hidden motives. They expressed news from other countries that they were getting via the grapevine, not anything really official, but they were receiving a lot of information. Sometimes they felt like it was too much information and they didn't know how to categorize the information. And it was very hard to know what was good information, reliable information, research-based information versus misinformation. So these were the things that they expressed to us in the focus groups. We also asked them how they would like to receive the information. One of the things that really stood out to me was how much they were reassured just by us being there, meeting with them face to face and having the conversation. And they placed a high value on that. And so as we left those focus groups, we began to really hone our strategies to overcome some of the barriers. We've worked on some educational videos by health professionals who are Spanish speaking, native Spanish speakers, and they were very helpful. We have also worked with doctors and public health officials to make videos that they could explain in Spanish to this population as well, some of the accurate and some of the research-based information. And we've had health officials at vaccine events to answer questions. So we have been involved in some on-farm vaccine events, and that is in our future plans to increase the frequency of those as well. So we, as I mentioned, developed some English-Spanish YouTube videos, and there's a link here that I can make available to you. But we had a variety of interviews that we did We had an owner of a farm who talked about the importance. We had nurses, we had a doctor, we had farm workers speaking who had received the vaccine and were encouraging their coworkers and their neighborhoods to consider it as well. And so we just had a wonderful time interacting again at the packing sheds, on farm, at the hospital with Spanish speaking professionals who really are passionate about this as well. And then we were able to share out these YouTube videos much further than just Georgia. So we were delighted to do that. Our next steps include partnering with those growers and ag producers who have Hispanic agricultural workers and providing continued education and vaccine clinics, access to vaccination, and our target launch for more clinics. We've done sort of the pilot work now, and our target launch to increase that work is March of 2022. In February, we're looking to train some of our faculty members in our extension offices to deliver and make these connections and further the work. And we want to be able to provide either, on site at extension offices or off site on some of our farms or some of our other places and partnerships, these vaccine clinics. So if anyone has questions, of course you can contact me or Dr. Maria Bowie, who is one of the PIs working with us on this. But it is delightful again to share this with you and to participate as a panelist this evening. Thank you so much.
Thank you very much. Ms. Gruner, please tell us a little bit about your organization. What challenges have you been seeing and hearing in the Latinx communities? And what opportunities and strategies are you using to address these issues? And finally, what opportunities exist for those who access this forum to participate or to contribute in your activities?
Okay, well, our organization was founded 15 years ago to work as immigrants to deal with all the challenges that we face here in Northwest Georgia. But regarding to COVID, the beginning of 2020, we started getting a lot of calls and messages about people asking, is this true? How true it is? And also where they could be tested. Because the only place at that time where they could be tested was the health department, and they were afraid to go to the health department because of immigration status, and also because the timing that they were offering the testing wasn't good for the workers, because we are a manufacturing area where the most of the carpets of the world are manufactured here. So their time, their job schedules is very, very difficult to be in the health department timing. And also, they were afraid of asking time from work because some carpet companies have a system that if you ask permission, probably they give it to you, but they are giving you negative points in your file. And also at the beginning, there were no materials in Spanish. It was very new, so it was sometimes not even in English, much less in Spanish. So we started looking for information. We developed our own flyers because we know that Latinos in general, we are more relational. We are not like, we need to have a close relation with the persons that we want to receive information. So we started asking the health department if they could help us to extend their hours, or if they could have bilingual people answering the phones. And it took a long time, but they were very good to do that. But then they were asking the social security number in order to be served, or if they had medical insurance. So many people were discouraged about testing. Um, then we were looking for options, because more and more people wanted to be tested, because they wanted to be tested, or because they felt sick and the job was asking them proof that they were tested. And also, many families started calling us that they were quarantined. They didn't have an option to get food. Then later, people were hospitalized, and then we started getting people who were dying. So in the middle of all this, we started developing materials, having Facebook Lives, um, getting food and deliver the food at the door of people who were quarantined, with flyers with information. Um, we were receiving people at the door with masks, providing also the information. Then we were getting uh, later, when the vaccine was started being available. Before that, we finally got support from the city of Dalton, and they were willing to go to our facilities, because if you want really to serve the Latino community, immigrants in poverty, they won't go to wherever they're gonna feel intimidated. So we asked the city if they were willing to work with us and bring someone to test in our facilities. And they say yes. So one of the consul women with her staff came to our facilities, and we were having testing now and then. But we realized that people wanted consistency and frequency, because it was difficult for them. When is going to be the next time? I don't know, let me ask. So we were asking, we need consistency. We want to tell people we're going to have testing this time, and this time, and from this time to this time. So in order not to lose people. Then when the vaccines became available, the city was helping us too. They were overwhelmed also with people that were going to the health department. So, and also we are all volunteers, so it was difficult to work full time plus helping with all this. And then we started canvassing the community. We were knocking at the doors with our flyers. We were visiting the businesses with posters. And then we realized that we needed help. We were working already almost 1.5 years without no funding, only volunteers, many hours. So I never there before to ask any funding from the city. So I wrote a proposal, and I told them, you uh, you also want the part of the community. We are 50% of the population here in Dalton. So we were asking, we are half of the population, we need help. So we developed a promotora project. That means the people that are lay workers were distributing information, visiting the houses, visiting the businesses. And also we started having vaccination events, first once a month, then twice a month, and now every week. And now it's a collaboration with the city, with the county, and also with CORE. CORE has helped us a lot with our events. So we have now weekly event of vaccines. We have vaccinated about 4,000 people, only Latinos, that they don't want to go anywhere else. And also we started last week with 2 events per week. And they told us today that we're gonna be able to have the pediatric vaccines. But it has been a combination of things. One was that we are a long-standing organization that people trust us, but we realized that we couldn't do it alone, that we needed to work in collaboration and to recognize the needs of the community, that they were afraid they couldn't leave work to get testing or vaccinated, that they didn't have information in Spanish. And sometimes there is information in Spanish, but it's a Spanish that is high registered that people don't relate to that. So that's why we created our own flyers or Facebook Live, posters that could speak to people and they would feel, oh, they're talking to me. I don't know, we have done a lot of things, but I just want to share a little video, if it's possible, and just some posts. Let me see if you, I don't know, share screen. Let me show you one of the videos. I think it's this one. Do you see it?
Not yet.
Not yet. Okay. You just let me know.
Okay.
No?
Not yet.
Okay. Well, I'll keep talking then.
Have
Also,
you, just to troubleshoot really quickly, at the bottom of your screen, there's a share button.
yes.
So if you press that button, then I can put it on the screen.
Okay. I think I did. No?
Not yet.
Okay. Then I'll just mention some other things that I wanted to say. In our area, we don't have public transportation, so it was difficult for people to go to the vaccine or the testing sites. Then we offer, we talked to some of the taxi companies if they could take people, instead of taking one person, to take more people into the vaccine site. And let me see if you let me know if you see something. If
Yeah,
not,
we see something now.
okay.
Okay.
Vacúnate, vacúnate, es por tu bien, es por mi bien, vacúnate, 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 que al cabo es gratis, es muy fácil y la encuentras al alcance, no le saques, vacúnate.
I'm gonna forward it. So that's an example of the
Wonderful.
of the canvassing that we were doing in not just the city but the county. And also, if you let me know if you see this other screen. Do you see something?
No,
No, not yet. Okay. Let me see. Share. Let me know if no.
Okay, we see.
We see ourselves.
Yeah,
Okay.
I don't know if that's what you.
No. Let me try. If not, then that's it. I just wanted to share with you some of the work that we were doing. It is. Just let me know.
We see it. We see it now.
Okay.
Yes.
So this was on December the 5th. Those are some of the examples of events that we have every week, and we provide an incentive for people who vaccinate for the first time. And we have our Facebook Live to talk about that. So those are just examples. This is a pediatrician talking about the importance of the vaccines for children. So we're doing a lot of things that are trying to engage the Latino community and to increase the percentage of people that are vaccinated. And so thank you so much. And we just wanted to connect the valuable information from health authorities and the local authorities with the community.
Well, thank you so much. Thank you for all of that great work that you're doing. Um, I'd like to shift a little bit to Dr. Stafford. You are a health equity champion, an esteemed physician who's practiced in both rural and urban communities. And since your retirement, you haven't stopped. You've continued your devotion to health equity in rural communities. Thank you so much for that work. What insights would you like to share with us tonight in addressing vaccine hesitancy narratives in rural Georgia? I see them all the time in the work that I do, and particularly the hesitancy within the African American community or the Black community that seems to be the epicenter of this hesitancy.
Well, I want to thank everyone for joining us on this call this evening. It's been good to hear what's happening in other portions of the state with other organizations. And in reference to my task of trying to give a perspective about vaccine hesitancy in rural areas, particularly with African American populations, I think I have had some exposure and some experience that kind of helps us address these various components, of which the problem of vaccine hesitancy, and as it is now being called, confidence, is being examined closely in terms of a proactive stance. In preparing my remarks, I came across an interesting diagram that I would like to share with you, even though I can't do it virtually, but I'm calling it to your attention that back in the late 20s, the World Health Organization was dealing with the issue of vaccine hesitancy with its population programs, particularly in reference to child immunizations. And they have developed a nice little diagram that helps explain some components that we frequently overlook in this country. It's based on what they call a psychosocial behavior approach towards understanding how do you move people who are reluctant towards vaccination to vaccination. And it starts out with two big categories. You have to examine the issue from the societal point of view as well as trying to understand what are people thinking and feeling in reference towards the question of motivation. In our experience in rural areas, our emphasis has been a disconnect between the practical issues of rendering immunization services and
Dr.
these two.
Dr. Stafford, I hate to interrupt, but if you could adjust your camera just a little bit, we can't see you. Yeah,
I'm sorry.
that's much better. Thank you.
Uh, uh, the other two components being the societal processes and what people are thinking. So efforts that I have observed that seem to be beneficial is trying to narrow this or eliminate this disconnect, moving people towards motivation. What we have experienced in my experience has been an approach of trying to address the issue of motivation on one hand, but at the same time trying to meet the practical issues, and that's commonly called patient demand and or expectations. So these problems are particularly evident in terms of the African American population in rural America. Now, in trying to understand how we move people from not being aware to being motivated towards vaccination uptake, what we have concentrated on is the issue of service delivery. And that's in terms of the response. And the end result has been that that has been a negative feedback into the hesitancy problem. I think all of us have heard or had the experience where we tried in the early days of this pandemic to try to do education around mitigation strategies, which were not very well received or accepted or understood. But as we finally got to the point of having some interventions, i.e. the vaccinations, because of the infrastructure in rural communities, we started having difficulties from the point of view of, first of all, patients knowing where to obtain the service because the infrastructure was so weak. Mm-hmm. And I'll just put an applaud for the innovation that the core group has brought to many communities in our state that are rural. Mm-hmm. And my community has benefited from its services. So mm-hmm. I'm putting in an applause and a request that organizations like CORE be recognized for the outstanding services it has rendered in rural areas of our state, particularly in rural underserved areas. They realized early on that in, if we were going to approach this issue from the point of view of trying to provide vaccination services, eliminating minimizing and eliminating these disconnects between the point of motivation and vaccine acceptance or uptake was a key component. And they built on their experience in dealing with their other programs, addressing the problem of what are the social processes that encourage motivation towards moving towards medical interventions. And they also made a very conscientious effort in terms of understanding what people are thinking. And from our Spanish colleagues this evening, I think there's been a very clear explanation of what our Hispanic populations are experiencing when it comes down to this question of what are people thinking and feeling about vaccinations. Now, another component that has been present in rural communities has been what is called in the psychosocial literature, and it is being embraced as part of the approach towards addressing this problem of vaccine confidence, is what is called direct behavior change. And direct behavior change is where you try to motivate people by offering incentives. And I think all of us have read and heard about the tens of thousands of dollars that have been given as an incentive towards moving people or motivating people towards vaccination uptake, as well as all the other amenities and support services that are out there. But many of these support services are one-time issues, one-time activities that I think as we continue to look at how we address situations in rural communities, it goes back to many of the long-standing problems of poverty that are so prevalent in our rural communities, particularly in the African-American population groups. So while it's a short-term intervention, and it has had some positive effect, but in terms of actually addressing the problem, I think we got another issue as we are dealing with variants and mutations on one hand, and the continued problem of disinformation, misinformation that is rapidly finding its way into our communities again, to say nothing about the psychological component of fatigue. So these are some observations that I'm trying to bring to the table for helping us continue to address this problem that is going to continuously be with us, because it's always been with modern medicine. The reluctance is just basically, in many aspects, human nature, the reluctance to accept something new until either the prospective recipient understands it or has externalities that in turn forces them to become participants in the health intervention.
Well, thank you so much, Dr. Stafford. That was very enlightening. Oftentimes, we don't have a lot of discussion about rural African Americans in particular, so that was very, very helpful. Uh, Finally, we'd love to hear from Dr. Foss, who will be sharing a little bit of insight on the latest myths. We've had so many myths about COVID and his expertise on COVID-19 and vaccinations. Dr. Foss?
Thank you for the opportunity, and it has been a delight to hear uh, the hard work that our colleagues are doing in rural health, specifically with underserved minorities like African American and Hispanics. And I'm just going to share some up to date data because numbers do speak volume. And for example, I just heard today about the number of cases that are being going up in the Midwest of our country. Uh, Out of those numbers, for example, in the state of Michigan, there's no beds because of the increased number of COVID 19 cases. In the Midwest, about 70% of the people hospitalized are non vaccinated. More than 80% in intensive care unit are non vaccinated. And more than 90% of people that are intubated because of COVID 19, and also people that are not vaccinated or unvaccinated. Here in the state of Georgia, we have about 51% people vaccinated. Uh, Over in the US, it's about 60%. Only 25% in the US has had their booster. Here in Georgia, 51%, like I said, are vaccinated. Only less than 20% have received a booster. Only 47% of Hispanics in our state are vaccinated, and about the same rate of 47% of African Americans. So I underserved minorities and those that live in rural Georgia, for example, some of your communities are not getting the vaccine. So let me talk a little bit about the myth that Ms. Womack mentioned. One of them is, well, how can we trust these vaccines? They came too fast. However, the science behind these vaccines have been there for years and years, probably decades. For example, the mRNA vaccines have been in research and have been used or a study for chemotherapy agents for cancer and other things for many, many years. So this is not new science. The one for Johnson and Johnson is very similar to the flu vaccine. The one for Novavax, the one that we are studying at Morehouse, and they have requested emergency use authorization for the FDA. The science is very similar to hepatitis B and the shingles vaccine. So these are no new science, and they would not rush. And the data is very good, and they have given hundreds and hundreds of millions of vaccination with very little repercussions, adverse effects. Now, the other one that we heard in terms of myth of vaccination is, well, if I get vaccinated, I'll become sterile. So I will not be fertile. There is no cases of male that with fertility issues that have been reported and that have received the vaccine. There's no such cases, number one. Number two, there's no data suggesting females can get pregnant after receiving the vaccine. And actually, there's a very good study that compare pregnant female that are pregnant that receive the vaccine versus those that did not receive the vaccine in terms of how many of them we had miscarriages, and there was no difference. So the vaccine does not cause miscarriage. That's another myth that can be put to rest. And there's some others, regarding side effects. And we know the side effects are very minor. They resolve within 72 hours. The most common is pain in the area of injection, a little bit of cold-like symptoms, headaches, some GI disturbances, but they're all resolved within 72 hours. There's some been cases of inflammation of the heart, most of them undiagnosed or not that much symptoms, and also very, very few cases, some cases of blood clots with the Johnson & Johnson, mainly on females that were younger than 50 years old. So they don't recommend that vaccine for our female population that are younger than 50. But also there were like 20, 25 cases only. And this vaccine has been given to many millions of people. So in essence, vaccination is very safe. If history tells the truth, flu vaccine, that's another pandemic that this country had to deal with in 1918. The flu vaccine is very safe and is given every year because of the different variants of flu that occurs in any given season. We know about smallpox, chickenpox, and others that now are mandatory for children to get before they got to school. So the science of vaccination and the history tell us that vaccination is very safe. However, I would tell you that there are other things that you can do if for cultural reasons, for conscious reasons, for religious reasons, you decide not to get the vaccine. There are other things that you can do that are very important in order to put a halt to this pandemic. Number one is the testing. Testing is not only important, but we have to do it regularly. If you have been exposed to somebody with COVID-19, if you have symptoms related very similar to COVID-19, you should get tested because that will help in terms of quarantine, isolation, and prevent the propagation of this infectious disease to others. And you can always do the 3 W's that I call: wearing a mask, watch the distance, 6 feet apart, and wash your hands. There's been good studies that shows that we can still help prevent the spread of this virus by doing those 3 W's. And I'll stop there to see if there's any questions regarding vaccination per se or boosters for the audience. And again, thank you for the opportunity to share.
Thank you so much, Dr. Foz. I'd now like to hear from Brittany Taylor to give us just an overview of the resources that are available from CEAL. Okay, and you're muted, Brittany. Down at the bottom of your screen. Yes, there you go.
Okay, I'm sorry about that.
No problem.
Sure. Give me 1 second as I get this up. But yes, hello everyone. Good evening, and thank you for joining. I am the project director for Georgia CEAL. And so I am going to be sharing a couple resources that you can use in areas where you live, work, and lead. So the goal of Georgia CEAL is to increase communication about COVID-19 and the COVID-19 vaccines, boost confidence and trust around COVID-19, and then to ultimately increase vaccine uptake around COVID-19, while also reminding everyone it's important to continue to test, especially with these different variants that are emerging. So make sure you are continuing to test as well. So here is an example of some of the resources that we provide. You'll see education on some of the variants, the side effects of the vaccine, which you can expect and you'll know it's working if you're feeling them, questions about the vaccine, how to mask up, as that's still important even if you're vaccinated. So we are funded by the NIH CEAL Community Engagement Alliance. And so you can also visit their website for information about COVID-19. And they also provide resources in the forms of fact sheets, toolkits, and even websites. And that is available in English and Spanish. Another resource is the We Can Do This campaign, which is a COVID-19 public education campaign. They are always constantly updating you on the various facets of COVID-19. You can go on to this website, and in that search bar, you just type in what you're looking for, and they provide resources for all these different target populations in various different languages. There's also the Greater Than COVID campaign. So they are partnering with the Morehouse School of Medicine president, and we have collaborated with them in sharing resources around where to find a COVID-19 vaccine and just COVID-19 in general. The next resource is Beat the Virus, right? So beating COVID-19. And if you just want some quick facts on COVID-19, you can visit their website, and there's always this yellow scrolling bar down at the bottom. Let's give you a quick update on how the vaccine rate in COVID-19 is going. Then we have Made to Save. So they focus on different segments of the population, and they also provide all of their resources and information in Spanish. And so what are we, Georgia CEAL, doing? So back around September and August, we launched a campaign trying to encourage everyone to get their COVID-19 vaccine based on asking what is their why? What is the reason that you got your COVID-19 vaccine, in hopes that sharing your why will encourage others to get vaccinated. And so we provided billboards, social media and phone pop-ups, and then also bus shelters, and those were done in English and Spanish. We also have a t-shirt where we wear them around, and we write in why we got our COVID-19 vaccine as another means of encouraging others to go ahead and get that vaccine. And more recently, we partnered with Combat COVID, and they hosted a COVID-19 Navigator training session. So Combat COVID is a federally funded organization, and they work to increase awareness about COVID-19 treatment and also clinical trials. And so they were able to educate everyone on addressing COVID-19 vaccines, how to recommend COVID-19 treatment options, and then how to reduce clinical trial hesitancy. And last but not least, here is just an overview of Georgia CEAL resources. So we provide fact sheets and information in English and in Spanish as well. We also distribute Georgia CEAL resource kits, and it has hand sanitizer, gloves, mask, a pen to write down important information. And then we also have a COVID-19 health equity dashboard focusing on Georgia and beyond, and that is through our partnership with our partners at Georgia Tech and also Emory. And last but not least, this is how you can get in touch with us. So you can reach us at georgiaceal@msm.edu, or you can just send me an email at brtaylor@msm.edu. And I'll drop some information for you all in the chat on locating a COVID-19 vaccine as well.
Thank you so much, Ms. Taylor. I'd like to take this opportunity to thank our panelists who shared some very useful, valuable, enriching information. And I hope everyone that joined us tonight learned a great deal. I'd like to end the night with Dr. Akin giving us a 20-second call to arms or call to action for us as we transition out of our discussion tonight. So,
great. Thank you, panelists, and thank you, Dr. Womack, for seeing us through this important discussion. I hope it has inspired you, educated you, re-energized you to continue to serve, live, and lead in all of the ways that you influence those you care about or those that you serve. So my call to action would be, Brittany talked about the importance of each of us knowing our why. What is it that drives us when we take each breath in and out? Why are we doing it? And who is depending on us to do that? And so for all of those reasons, our call to action should be to be safe, for those that depend on us, and then also for all of those things that motivate us to continue in our efforts to live, to lead, and to last. So certainly, as Dr. Foss and others talked about, it's important for us to do our 3 Ws. And if you have not been vaccinated, to seriously consider your why and think about getting vaccinated. So for all of those things we cannot control, vaccinations have worked. COVID just happens to be the newest thing, but we know vaccinations have protected us. Science is credible, and certainly community engaged voices and influencers help to ensure that those messages are credible and we can get back to being a healthy Georgia.
Thank you so much. And good night to all. Thank you for joining us. Bye-bye.